Welcome everyone to the AME research meeting. We are delighted today to have two speakers and to really have a very interesting topic about digital health. I'm going to introduce for the speakers and I will hand it over to them to have a presentation followed by the questions. So first we would like to welcome Fonette Fonjungo. She's a fourth-year medical student at Meharry Medical College and a medical student researcher at Stanford Dermatology. Fonette was born in Silver Spring, Maryland, and grew up in Cameroonian family that cultivated her interest in culture and community. This led her to pursue a Bachelor of Science in Public Health at Syracuse University. She subsequently completed a Master of Biomedical Science at Rutgers University School of Graduate Studies. And during her graduate degree, she was selected as USAID Research Fellow. And through her career, she has been involved in so many different initiatives that brings community and focus on clinical dermatology. So she really has a passion towards psychosocial impact of chronic disease on skin color and health equity. So we're delighted to have you. And our next speaker is Edward Eid, and he is a Lebanese dermatologist and a postdoctoral research scholar at Stanford University, like me, okay, and works with esteemed Linus and Tangs Lab, and graduating with honors from the American University of Beirut. He gained expertise in dermatology and a commitment to helping those with skin conditions. Edward focuses on genetic skin disease, contributing to research efforts and embracing telemedicine as an alternative in-person care in dermatology. He's passionate about mentorship and driven by the dedication to improve dermatology patient care. So with that, I would like to welcome you both, and we're really delighted to have you.
Thank you. Thank you, everyone.
I'll hand over for you to share screen, and then once we're done, we'll have a facilitated discussion. So don't know who's going to be sharing screen.
I will share my screen first. Let me go ahead and do that. Can everyone see my screen? Yeah, okay. Well, good afternoon, everyone. As Ala mentioned, my name is Fonette Fonjungo. I am a fourth-year medical student at Meharry in Nashville, and I've been working with Dr. Eleni Linos here at Stanford for the past year. And of course, my colleague, Dr. Edward Eid, is also here with me, and we will be presenting today. Unfortunately, Dr. Linos is out of town, so she's so sorry she cannot make it, but we are so grateful for Amy to be presenting here, because Amy was the Kickstarter for the funding for this project. So we're really grateful to be able to be here to share what we've been doing thus far and how we've been using digital technology for the home-based monitoring of skin diseases. And we do not have any conflicts of interest to report. So starting off, as we know, since the COVID-19 pandemic, that has really changed how we interact with technology. Telemedicine specifically has existed for decades, but since the pandemic, its adoption has accelerated immensely, as you can see with the peak that happens around March 2020. And given these trends, the use of telemedicine for dermatological care will likely continue to be incorporated into standard practice. We believe this rise in popularity can really benefit dermatologists and their patients. In terms of skin diseases, there are 2 billion people worldwide dealing with skin disease. In America, 25% of Americans have been diagnosed with some kind of skin condition. Management of chronic diseases in particular makes up about 64% of dermatology visits. And when we look at possible reach through smartphones, there are 6.65 billion people in the world who use a smartphone. Here in America, 85% of Americans use a smartphone, and there are about 87 million who use some type of health or fitness app. So we really have been trying to maximize the way to use digital technology for management of skin disease, given these statistics. So skin disease, as you can see on this graph, the severity can really vary over time. There's peaks and valleys, there's ups and downs, and depending on when a dermatologist is able to see their patient, this can allow them or cause them to make different conclusions about the disease severity, and that can affect treatment options. And you can see here, if a dermatologist was to see the patient in January versus April, that can really affect the conclusions made from the patient. So we have figured that given that it would be incredibly important to have sequential photos that are collected remotely for providers to be able to better recognize what is going on with their patients. And in order to really figure out what the challenges of teledermatology are, we conducted qualitative interviews with 23 dermatologists. These interviews actually specifically focused on experiences of using telehealth with older adults that allows us to really identify issues with accessibility for telemedicine. So from those interviews, we came up with 5 experiences and 5 recommendations from the dermatologists. So we'll go through the experiences one by one. First of all, their dermatologists found that there is a benefit for telehealth for older adults. Secondly, they felt as though telehealth is more beneficial for stable chronic diseases. They felt that there were some concerns about diagnosing malignant lesions via telehealth. Next, they felt that technology, it does present a barrier for many people, but not all older adults, so something to keep in mind. Thirdly, they did make the important point that with telemedicine, you cannot view the whole patient and you can't feel the skin, which is an important part of dermatological care. And then finally, of course, communicating virtually is not the easiest thing. So they did report it can be more difficult to communicate with patients virtually. So some of the recommendations that we were able to put together based upon these experiences, one with the possible benefit of telehealth for older adults, really making sure that we're giving comprehensive instructions to our patients so that they can best utilize these applications and platforms. Secondly, making sure that we are having appropriate triage of the patient before they have their appointment, and that is crucial to evaluating the disease and making sure that we're catching everything that is necessary. Next, this is something I'm sure we all have to keep in mind, not to make assumptions about people's comfort with technology, even though there are 6.65 billion smartphone users. We have to remember that comfort levels can vary. And then next, it is very important to manage the patient's expectations about what exactly we can do with telehealth, as for this specific experience, the difficulty with palpating the skin and not being able to see the whole patient does limit the overall ability to care via telemedicine. And then finally, the last recommendation is that we need to make telehealth accessible for all. So next, given all of this, with all this in mind, we started collaborating with IDEO, which is the global design and innovation firm in Palo Alto. They actually are the ones who famously designed the first mouse from Apple. So with the feedback from patients and providers in IDEO, we designed what is called DORA. So DORA is a novel text-based user-friendly virtual assistant, specifically for dermatology patients that we are currently developing. And using a prototype design, we conducted a pilot study with older adults. So for this pilot study, the eligibility criteria was adults who were English speaking and older than 70 years old with any skin disease, and they had to have access to a smartphone and show no signs of cognitive impairment. We were able to recruit 62 patients, and you can see their demographics here, between August to December 2021. And for this pilot study, the structure was patients were asked to submit weekly photos and answer a symptom questionnaire about a single skin lesion for 4 weeks. And then after that, they answered these for 4 months, monthly for 4 months, and then monthly for 5 months. And then a final request was made at the 9-month mark after the baseline photo. So from this study, we were able to evaluate the feasibility of this system, the usability and the clinical utility of DORA, as well as the participants' compliance with the system, the retention of this overall system. And we also were able to measure the participants' satisfaction with this app using what's called MOC, or the mHealth app usability questionnaire. So from the pilot study, the mean follow-up was about 26 weeks. We also measured the response time, and the median time was about 2 days for patients to upload, complete their surveys, upload their photos, and answer the questionnaires. 76% completed requests for photo submissions, and then 74% completed symptoms questionnaires. And this is an example of the sequential photos that we were able to collect. You can really see the change in disease. sorry, let's go back. We can really see the change in the skin, and DORA has been really, really helpful for narrowing down diagnosis and also ensuring that there is follow-up with the patient. So it's great to really see this physical images, so you see what is exactly that we are collecting over time, and then add that with the symptoms and questionnaires that they're able to answer. So in terms of the photo quality assessment, we did measure photo quality, and the way we did this is we had 4 dermatology clinicians evaluate the first 88 photos from 15 patients. We also asked them how comfortable they were with triaging, diagnosing, and providing treatment recommendations based on the photo series. So this is the scale that we use. Dermatologists rated 49% of the photo series generally good or perfect quality. And you can see here over 80% of photos had at least a C rating or better. And then, of course, we did also ask for those important things, the triage, the diagnosis, and treatment comfort. Overall, good comfort or good confidence in triaging skin disease via these photo series, and then about moderate confidence in diagnosing skin diseases and providing treatment recommendations. So again, we asked what were the main things that were needed in order to improve physicians' confidence in diagnosing and triaging and giving treatment recommendations via these photo series. And they gave 3 recommendations, one being that the photo quality needed to be improved. 2, the lesion of interest should be indicated in the photo when the patient takes the photo. And then also providing some type of clinical information about the lesion and the patient when reviewing these photo series should be considered. So those are the things that we've learned thus far, and we are really excited about what we've learned. These findings have furthered our research thus far. We've been looking at different skin diseases, and Ed's going to talk a little bit more about where we've been going thus far. I'll go ahead and let you share, Ed.
Okay, so thank you, Fonette. Good afternoon, everyone. I am Edward Eid, and I will continue with part 2 of our talk. So after our promising results with DORA for older adults, we decided to generalize its use across all ages and skin tones and to broaden its scope. So aside from its initial use at monitoring skin conditions remotely from home, we also want to use DORA to assess symptoms and psychosocial impact of skin diseases and to correlate them with patient-submitted photographic data and clinician data. Moreover, we want to develop a longitudinal image library of skin diseases that can maybe someday be used to inform AI-driven predictive algorithms. To achieve those next steps, we started using DORA to gather patient-submitted data from 4 cutaneous diseases: eczema, rosacea, hidradenitis suppurativa, and infantile hemangioma. Now, these 4 conditions were chosen since they demonstrate some of these salient clinical findings seen across skin diseases. Eczema, for example, has erythema and scaling. Rosacea has erythema, papules, pustules, and telangiectasias. Hidradenitis suppurativa has comedones, nodules, and sinuses. And infantile hemangioma is a well-circumscribed erythematous plaque or nodule that can ulcerate. Depending on the condition, we collected patient data through DORA, either on a weekly or bi-weekly basis. Besides image and demographic information, such as age, sex, race, and employment status, we also requested symptoms-related and quality-of-life data. For symptom and symptom severity surveys, we asked participants to fill validated questionnaires, such as the Pain Visual Analog Scale for hidradenitis suppurativa, the POEM survey to assess disease severity in eczema patients, and the Patient Self-Assessment Scale to gauge erythema severity in patients with rosacea. For quality of life, we requested the validated IHQOL and ROSA-QOL surveys for infantile hemangioma and rosacea, respectively, and the Skindex Mini for the rest. And finally, we chose Stanford RedCap as a repository for our data, as it is HIPAA compliant. With the help of clinicians from the Department of Dermatology here at Stanford, we managed to recruit 116 patients who contributed a total of 1,550 images across our 4 studies. We have finished recruiting and data collection for both rosacea and hidradenitis suppurativa, and both of these conditions currently make up the bulk of our data set, with 78 patients contributing more than 1,150 images. For infantile hemangioma, we are still targeting a few patients, so we are nearly at goal. As for eczema, recruitment is unique in that it is exclusively being done through flyers distributed around Stanford and Stanford-affiliated clinics and hospitals. And recruitment for that project is also still ongoing. So data collection from participants is set to run for 3 months for eczema and 1 year, up to 1 year for infantile hemangioma. During data collection, DORA proved very useful in showing the longitudinal natural history of hidradenitis suppurativa, which is a chronic cutaneous condition that tends to target the folds. These pictures capture the nodules, sinuses, and rope-like scarring that make up the left axillary HS this woman is suffering from. Now, from baseline to week 10, the nodules noted at baseline seem to be ulcerating, with surrounding hyperpigmentation and possible sinus formation. At week 16, however, the condition flares as the ulcers in question begin expressing pus, and the flare persists from that point onwards. Symptom and quality of life data collected through DORA is also very useful in describing the course of HS. In this graph, pain scores and Skindex quality of life are graphed as a function of time. And though not perfect, both graphs correlate well with each other. The peaks in this graph, such as those noted on weeks 1, 5, 13, and 16, represent HS flares, which are periods of maximal pain and low quality of life. It is also worth pointing out that the large fluctuations seen here, taken together with the longitudinal images, demonstrate the unstable nature of HS in the left axilla of this patient. While collecting data for HS, we also noticed how challenging folds are to photograph. Pictures are occasionally either poorly lit because of shadows and difficult angles, out of focus because of the difficulty of focusing the camera on topographically complex areas such as folds, or blurry because of the poor visibility and difficulty keeping a steady hand while imaging. And to address these issues, we advise patients to use a mirror for visibility and to increase lighting, or to altogether have a family member or partner take the photo if feasible. For rosacea, a chronic inflammatory facial disease characterized by redness, facial lesions, and tiny blood vessels called telangiectasias, factors affecting photo quality included makeup, which tends to mask the erythema and the lesions, and glasses, which tend to distort the erythema of rosacea and blur the borders between erythema and normal skin. And as you can see here, after re-uploading makeup and glasses-free photos through DORA, photo quality and rosacea visibility improve significantly. This series of images is of a patient with moderate to severe rosacea, and notice how the lesions over the cheeks and forehead change in size, number, and position over time. To also note that lighting is of particular importance in adequately capturing erythema, and we always recommend taking photos in a setting with plenty of natural light, as it generally yields the best result. In this graph, patient erythema scores and Skindex mini quality of life scores are plotted over time for another rosacea patient. And while the correlation is somewhat weaker than that seen for HS, notice how both scores are generally trending upwards, showing general worsening of the condition, which eventually culminates in week 20, which has the highest erythema score and the worst quality of life score, and is clinically mirrored by the worst erythema on longitudinal imaging. For eczema, a multifactorial cutaneous condition characterized by ill-defined scaly erythematous plaques, DORA was also helpful in tracking changes. The red scaly plaques noted on the left axilla at baseline have gradually improved over time to be replaced by post-inflammatory hyperpigmentation at week 10. Finally, for infantile hemangioma, a congenital vascular proliferation appearing at or near birth and that tends to enlarge and then regress, DORA has helped in tracking changes in ulcerations. The large ulcer seen in the first picture of this infantile hemangioma at baseline has progressively shrunk in size and depth. Now, in a bid to bolster DORA and achieve our next steps, Dr. Eleni Linos has recently obtained this R01 grant titled Novel Digital Tools for Home-Based Monitoring of Skin Disease. Now, a major aim of this R01 is to use DORA to create a representative longitudinal image dataset of common skin diseases that encompass all skin types. We have just started recruiting for this major project, and we'll be looking to oversample skin diseases from African American and Hispanic patients in a bid to address the current underrepresentation of skin of color images in dermatology generally and AI training datasets specifically. Furthermore, as part of a major collaboration with Dr. Anthony Oro and Dr. Jean Tank, DORA will be used to monitor recessive dystrophic epidermolysis bullosa wounds from home. We will be monitoring how these wounds change over time by collecting longitudinal patient-submitted DORA wound images and by correlating them with patient-submitted pain and itch severity scores, wound impression scores, and quality of life measures. For these projects, we are mailing participants green stickers for use during imaging. The green sticker is 1 inch in diameter and allows image analysis software to accurately define condition size. For epidermolysis bullosa, participants are taping the green stickers on rulers, since sticking the green sticker on their fragile skin might induce blisters. Finally, the Linos team would like to thank Amy for their amazing contributions to our awesome project and would like to thank you all for listening.